Today we'll start a discussion of Chapter 15 in our textbook on the special senses. This will wrap up the first semester of Anatomy and Physiology. We'll start out talking about vision and then go on to olfaction in this part 1 of Chapter 15. So first, let's take a look at some superficial anatomy of the eye and the surrounding structures. Very familiar looking surface anatomy here on the left, and in the eyelid, let's look over to the right, we can see the eyelid is like a flap of tissue with some muscle and a stiffening tarsal plate. We'll call these eyelids from now on palpebra. Within the palpebra are hair follicles, the eyelashes are there, and there's also tarsal glands and ciliary glands in the eyelids. The tarsal glands are modified sebaceous glands, and the ciliary glands are sweat glands. So we have some moisture and some oil coming out, which, as we'll see a little bit, along with the lacrimal fluid, keeps the surface of the eye moist all the time. There's also tarsal glands and ciliary glands in the lacrimal caruncle here, at the medial aspect of the eye opening. We should also note in this diagram on the right something kind of cool. The front of the eye is covered by a connective tissue membrane called the conjunctiva, and it kind of folds over and attaches to the inner surface of the palpebra so that it seals off the posterior parts of the orbit from whatever debris and so forth may come from outside the body, as well as keeping the lacrimal fluid on the surface of the eye, which will then eventually, as we'll see, travel into the nasal cavity. So that's the white part of the conjunctiva. Continuous with the conjunctiva is this transparent part of the anterior of the eye, the cornea. So light travels unimpeded through the cornea, which incidentally is covered with a layer of epithelial cells, a live layer of cells on the surface. The cornea has no blood vessels in it in order to help retain its transparency, and those live cells receive all of their oxygen for their metabolic needs from the air. And the oxygen diffuses right through the lacrimal fluid into the cornea. Pretty cool. Some homeostatic imbalances. If a tarsal gland becomes blocked, it may result in an accumulation of oils in a structure called a chalazion, a bulging cyst in or around the eyelid. There also could be an infection in one of the glands, and that produces an inflammation called a stye. Children are often subject to getting styes, infections of those glands, because they're less fastidious about their touching their eyes after handling any number of different insalubrious materials. So conjunctivitis. What if there's an inflammation of that white connective tissue surface of the anterior of the eye? Inflammation, as we know, results in vasodilation, or is associated with vasodilation, and so that white of the eye starts looking very red. Pink eye is just a sort of colloquial nickname for inflammation of the conjunctiva, conjunctivitis, particularly caused by bacteria or viral infections. Often this is a very contagious condition and can spread through populations of especially school children. So here's a diagram that shows a little schematic of the lacrimal system. And if you go down into the lab and find one of the skulls that down in the back of the room where we have all the bones, and run your finger right along the superior inner surface of the orbit, you'll feel it's quite symmetrical, it's quite spherical until you reach this area, and you'll feel an indentation. There's a spot there for the rather sizable lacrimal gland to sit. The lacrimal gland produces the tear fluid, which then washes across the eye, carrying dust and debris and bacteria and what have you out of the eye into the canaliculi here and down into this duct into the nasal cavity. So if you poke yourself in the eye or it starts watering, you'll immediately notice your nose start running. The lacrimal fluid is antimicrobial. So oftentimes there's microbes floating through the air that strike the surface of our eye and get into that lacrimal fluid. Well, it has lysozyme, which is an enzyme that breaks down bacterial cell walls, and they therefore experience lysis. There are antibodies, which are defensive proteins made by your immune system that can help block infection by various microbes. So besides just mechanically washing your eye, There's these antimicrobial properties. Movements of the eye are produced by skeletal muscles. There's 6 skeletal muscles that attach to the eyeball and allow you to move it in any direction, elevate, depress, as well as turn it in any direction. The elevation and depression are largely to keep the eyeball essentially in the same position in the orbit while it churns in different directions. So there's 4 symmetrically placed muscles you should know. They're called rectus muscles, and they're just a medial, lateral, superior, and inferior rectus muscles. These ones right here and up here, down here. And then there's 2 more additional muscles. There's the inferior oblique, which originates on the medial wall of the orbit, and then inserts onto the lateral aspect of the eye, on the sclera of the eye, as we'll see. And then there's another, the superior oblique muscle is seen here. It's kind of interesting. It has a tendon that travels through this little loop, this little pulley called a trochlea, and then inserts onto the superior aspect of the eye. And so those muscles allow us to turn the eye and elevate and depress the eye, along with those rectus muscles. We already know the nerves that control all those eye movement muscles, so they're just listed here for a review. Abducens, oculomotor nerve, and trochlear nerve. Those cranial nerves help us move the eye. We do not need to memorize the corresponding muscles that each one of those nerves controls, but just to remind you that these are the muscles that move the eye in any direction because of the activation of those 6 muscles. Another homeostatic imbalance, double vision, diplopia. If you're from Rochester, when you hear the phrase double vision, you probably think of a hometown band called Foreigner. I guess I'm dating myself a little bit there. Anyway, diplopia, if the muscles that control both eyes are not coordinated so that the eyes point at the exact same part of the field of view at any one moment, then you'll see 2 images. So we have this double vision effect. Strabismus is what it's called when there's an exceptionally in discontinuity between the position or the pointing of the eyes. One eye may be way, way out of whack with the position of the other eye as far as pointing to the same part of the field of view. Oftentimes, if you're in conversation with someone with strabismus, you'll notice that maybe they will shift from eye to eye, whichever eye is the one that they're going to pay attention to, the part of the field of view that they're looking at. In childhood, if there's this problem, sometimes one of the eyes will just become permanently disregarded by the brain because it's easier just to always go to one eye and use that as the input for visual perception. But the problem is, eventually that other eye may become essentially blind. Your brain no longer pays any attention to it. So when children have strabismus, they'll oftentimes be treated with eye patches to force whichever eye is becoming the weaker eye to be focused entirely upon, and they'll strengthen up the brain's directing of that eye and analysis of its vision so you can keep both eyes together, at least strong. All right, how about some anatomy of the eyeball itself? And the eye has 3 layers, or tunics. Tunic just is a kind of old-fashioned name for jacket. The outer layer of the eye is called the sclera, and it's just collagen, connective tissue, and elastin. Your eye is like a rubber ball, an elastic ball with pressure inside, so it's very springy and kind of bouncy, and the sclera is responsible for that. And then on the anterior part, continuous with the sclera, is the cornea. You saw that the conjunctiva is attached right to the surface of the sclera here and folds over onto the palpebra. Anyway, there's the transparent cornea. And then deep to the sclera is the choroid. So the sclera is sometimes called the fibrous tunic because it's collagen fibers and elastin. The choroid is called the vascular tunic because it's densely packed with blood vessels, and it's actually highly pigmented. It's very dark. If you were able to actually peek in at this on the eyeball, you notice it looks black because rays of light that enter the eye will either be absorbed by photoreceptors and transduced into impulses your brain can understand, or it will be absorbed by pigment in the choroid so that it doesn't reflect and bounce all around in the eye and kind of cloud things in terms of the clarity of vision. And then inboard to the choroid is the retina, a very metabolically active part of the eye because it's where all the neurons are, the photoreceptors and neurons, and you know that the nervous system is extremely metabolically active, and so the choroid has the blood vessels that will feed much of the retina. The retina also has some blood vessels entering through the optic nerve, and forming a pattern on the surface. So you see all these blood vessels on the surface of the retina. That again helps feed some of those very hungry neurons that form the neural part, the neural tunic of the eye. Let me direct your attention to a part of the choroid, though. You should look at the choroid has a specialized region here in the anterior. It's a ring of smooth muscle that surrounds the lens. Here we're seeing it just as two blobs, but that's because we're looking at 2 dimensions at a 3-dimensional object. If we could look head on at this, we'd see that there's a ring of muscle around the lens, and the lens is connected to that ring of muscle by what's called the suspensory ligament, or ciliary zonule. And that essentially forms a boundary here between different parts of the eye. And we'll take a look at that. What is filling up this space posterior to the lens? This entire space posterior to the lens and the ciliary zonule is the posterior segment of the eye. That is filled up with a gelatinous material called the vitreous humor. It's in there from development, and it stays in there your whole life. Vitreous humor. There's actually a little tunnel through the vitreous humor that represents a pathway by which some of the cells that produce the anterior structures of your eye migrated through during development of your eyes. Pretty interesting. All right, so anterior to the lens and the suspensory ligament is the anterior segment of the eye. So everything anterior to that. Just to confuse things a little bit, the anterior segment is divided by this boundary here, the iris. The iris is a flap of smooth muscle and tissue that's part of the choroid that sits anterior to the lens, and the space between the lens and the iris is called the posterior chamber of the anterior segment. And then here in the front we have this anterior chamber of the anterior segment. It turns out that the ciliary body, which has this ring of smooth muscle, also has secretory cells that produce a watery fluid called the aqueous humor. And we'll see more about that in a little bit. All right, a couple more things we should note briefly before we go on. If we're thinking about the retina, it's where all the photoreceptors are that can transduce light photons so you can see. But when you're using your eyes for any kind of detailed vision, you're really only using a tiny little patch of the retina called the Macula Ludia, and the very central part of which is the fovea centralis. It's the most densely packed photoreceptor array in your entire eye. And now you can see a little bit of a precarious concept that you only use this tiny bit of your retina for real sharp, detailed vision, and so it's not like you have a lot of reserve for anything happening to that little field of receptors. So that's where all the good vision happens. Another thing we should note is that where the optic nerve attaches to the eye, there's some blood vessels, as we said, entering through the middle of the optic nerve. Right at the point where those enter and exit the eye, there's no photoreceptors there. It's like a blind spot. It's called the optic disc. So one spot on each eye has no visual data going through the optic nerve to the occipital lobe. Referring to the iris, we saw that muscular flap, that extension of the choroid, and if we look carefully, we can see that there are some circularly arranged smooth muscle cells and some radially arranged smooth muscle cells. Activating parasympathetic neurons causes the circular fibers to contract, which constricts the pupil and lets less light into the eye. And activating sympathetic neurons activates the radially arranged smooth muscle and dilates the pupil. This is just the opening in the iris. It looks black because, why? Because light rays entering the eye never come back out again. They're absorbed by the choroid, so it's dark in there essentially. So it just looks black. All right, let's take a closer look at the retina now, the neural tunic. And if we look at this cartoon, we can see that there's 3 rows of cells in the retina. There's actually another layer of cells, an epithelium, on the outermost part of the retina. And so we should take a closer look at those 3. What are those 3 layers of cells, and what's their contribution to vision? Before we do that, here's a quick picture, an actual photograph of someone's retina taken with an ophthalmoscope and a camera. And you can see there's this pattern of blood vessels that here's where the optic nerve lies, the optic disc, no photoreceptors, but blood vessels entering and exiting the eye. And the pattern of blood vessels on your eye is unique to your body. Nobody's pattern of blood vessels is the same as yours. They're all kind of random. And so you may have heard of using retinal scans for personal identification. What's happening is making a digital image of this pattern of blood vessels and using that to identify you since it's unique. We can also see the Macula Ludia. So if someone is clinically interested in the condition of your eyes, they might make an observation like this image and take a look at the macula and see what its dimensions are and how it's looking and so forth, and see what the health of your eye is. Now we'll zoom in a little more on the cells. What do we got? Light rays entering the pupil, traveling through the anterior chamber, posterior segment of the eye, and now hitting the retina, traveling through a mat of axons of this first layer of cells that are struck by the light, or actually ignored by the light as the photons pass right through it, relatively transparent layer of ganglion cells. And then the photons pass by another relatively transparent layer of bipolar neurons, these pink-colored neurons, and then finally will be absorbed potentially by the photoreceptors. They're in the outer of the three layers of cells in the retina. And that's where the actual photon transduction happens. The energy of the photon is going to be converted to action potential impulses. The photoreceptors are kind of sort of jammed into an epithelium called the pigment epithelium of the retina. So you can see them all kind of anchored in there. And so light rays travel to the back there, and then some changes are going to take place in those photoreceptors, which impact the bipolar neurons. And finally, action potentials for the first time will be formed in these ganglion cells. Right, that's the very first impulses that are actually formed, and then those impulses will travel along the axons you see in this layer, out through the optic nerve to the thalamus and to the occipital lobe of the brain, the cortex. Here's a micrograph. It's pretty cool. You can see the pigment epithelium. This is the choroid, the super pigmented area, right? That's going to absorb any stray photons. The pigment epithelium of the retina, you can see some pigment here. And here are the nuclei of the photoreceptors, the nuclei of the bipolar neurons, and the nuclei of the ganglion cells here. So those are the three layers of cells we just been looking at. Let's take a look at the formation of the aqueous humor, that watery fluid that's produced by the ciliary body. Some of that fluid is going to be produced here and flow through the posterior chamber of the eye, of the anterior segment, and then flow out through the pupil opening in the iris into the anterior chamber, and eventually pass through the canal of Schlemm. The scleral venous sinus is an array of tube-like trabecula of tubes, they're called, that allow the blood or the fluid to go back into the venous blood. So we have cells. This is a very familiar theme, right? We have some cells producing a secretion, and it's going to enter into this chamber and then be recycled. And the rates of production and recycling must remain constant and equal in order that the volume of the eye stays constant. What if the volume of the eye was to increase? If the fluid was not able to get through the canal of Schlemm adequately quickly, then the volume of the eye will expand, stretching that sclera, stretching the wall of the eye and increasing the pressure in the eye. That's a condition called glaucoma. If you increase the pressure in the eye, you might not think much of that as long as your eye doesn't get really enormous. The problem is increasing the pressure in the eye when you have glaucoma will start to cause degeneration of the macula. You'll eventually start eroding away the photoreceptors in that all-important macula and fovea, and eventually you will become blind. So every time you go to the optometrist or ophthalmologist, they will always do a test for the pressure inside your eye, either by mechanically pressing on the eye with a special instrument to see how easy it is to dent in the surface, or they'll shoot a puff of compressed air at your eye to see how much it deflects. And from those observations, they can calculate the exact pressure inside your eye. And if it's too high, they can give you some eye drops that will help, some parasympathetic agonists that will help alleviate that pressure by letting more fluid out through the canal of Schlemm. There are actually surgeries to help increase the rate of discharge of that fluid if necessary. How important is that? So you don't want to get glaucoma and just keep it. There's no symptoms of it, so you should, even if you don't wear glasses, you should go and see the ophthalmologist or optometrist every year and have your eyes checked out and also have that glaucoma test done. Here's another type of homeostatic imbalance. This is a cataract. As you age, the lenses in your eyes slowly start to yellow ever so slightly, and as time goes on, your vision starts to become slightly impaired by the less transparent nature of your lenses. But some people have a very advanced state of this sort of degradation of the transparency of the lenses. That's called cataracts. So here's a bad cataract, and the person is not going to be able to see much, and so there's a surgery to remove that opaque lens, get it out of there, and replace it with a clear plastic lens to allow focusing light. And it's a really dramatic thing. If you go from having cataracts and not really being able to see, maybe even being functionally blind, to having perfect, crystal clear, bright color vision, boy, that's a real exciting kind of a thing. So it's medical practice is miraculous in many aspects. Here's a really cool example. This illustration is going to tell us something about the photoreceptors. So before we talk about that, I just want to mention a little bit about the photoreceptors. The rods, they're so-called, are drawn in purple right here to illustrate that there's a couple of different types of photoreceptor. Rods are these skinny purple ones. Cones are these yellow ones that look kind of like little squids. So there's rods and there's cones, and they have very different properties. They contribute very differently to the overall perception of what's in our visual field. I thought I had a little table to talk about the properties of rods and cones. It'll probably appear later, but I just want to mention quickly. Rods have the following properties. They're very light sensitive. They don't need much light. They operate in very dim light, potentially, but they produce only monochromatic vision. We call it black and white. Monochromatic means one color. There's only one population of cones, or rods, I'm sorry, and they only therefore produce one kind of color vision. They also produce kind of fuzzy vision. The rods are kind of funneled, their inputs are funneled into bipolar neurons. You can see these three rods all synapse with the same bipolar neuron. Sometimes you might see that actually all these rods down here synapse with bipolar neurons, which in turn funnel down into one ganglion cell. And so once the impulses from this ganglion cell reach the visual cortex, there's no way of knowing where the photon actually struck that's being analyzed. It could have been anywhere in this area where all these rods are. Whereas the cone cells are cells of color vision, and they produce very sharp vision potentially. Part of the reason for that is that each individual cone synapses with one bipolar neuron, which in turn synapses with one ganglion cell. There's a one-to-one correspondence. So when an activated cone cell creates impulses that are sent to the visual cortex, we know exactly where that photon struck the retina, so hence we have more detailed, sharp information about the visual field. If we were looking at the fovea centralis, it wouldn't look like this. It would be packed with cones, because that's the receptors for our best vision. Few rods in there, but packed with cones and super accurate or high acuity vision. All right, so back to this graph. Why do we have this graph? This is to illustrate that there are actually three families of cones. Not all cones are created equal, and the cones, different families of cones have preferential or peak wavelengths of absorption. Wavelengths refer to the distance between the little peaks of a waveform as it travels through space. Photons of light are packets of energy that also travel like waves, oscillating up and down. And if we look at the distance between each of the tops of the waveform peaks, we can ascribe a wavelength to each different color of light. So these numbers represent the number of nanometers. What's a nanometer? It's a shockingly small measure. If you think of a micrometer as a millionth of a meter, let's go 3 orders of magnitude, 1,000 times smaller than that to get a nanometer. So these are very small wavelengths, but anyway, different colors of light have different wavelengths, and different families of cones absorb preferentially different wavelengths of light. So we have red cones that have the maximum amount of light absorption at 560 nanometers. and then it kind of falls off as we move in wavelengths up or down from that. There's some overlap, though, because the green cones absorb preferentially at 530 nanometers, and then their absorption falls off as we move away from that wavelength, and so forth. So by analyzing the degree to which each of the different types of cones are activated in any part of the retina as you're looking at something, your cortex can figure out millions of different color shades. So you only have 3 types of cones that absorb preferentially at 3 wavelengths, but because there's overlapping absorption, we can analyze those 3 different families of cones and see millions of shades of light. It's a miraculous thing. Special senses are pretty and special indeed. And we can also see that rods have a preferential wavelength absorption, but there's only one type of rod, so they're monochromatic. Now we need to look at the optical properties of the eye, so we need to look at refraction. What in the world is refraction? Refraction is the bending of light, rays of light, or photons of light as they change, as they travel from one medium or substance into another. If a photon or a ray of light strikes the boundary between 2 different substances, and it strikes it at anything besides a 90-degree angle, it will change direction. Isn't that strange? And we've been encountering it all of our lives, and here's an illustration of it, and that's the reason. So the velocity of light rays in any one substance is unique. So as light rays, for example, travel from the air into the water in this glass, there's a very different speed of travel in the water, quite a bit slower. And as the photons make that transition from the air to glass to water, they change direction relative to just going through glass and air. And hence we have photons that got bent and come to our eyes in a different location or position than these. Same straw, different position it looks like because of the bending. So that's refraction. And this is something that our eyes depend on. Lenses are devices to control refraction. You have a lens in your eye that causes refraction, bending of light rays, to allow us to take light that's reflected from objects in our field of view and focus that light onto our retina so we see a sharp image. Incidentally, when the light rays reflect off some object in our field of view, and an image is formed on the retina, it's reversed and inverted upside down. Isn't that interesting? So the little colored squares were drawn here to illustrate to you that if this was the image we were looking at, here's how it would appear on the retina. That's just a little fact about optics. So here's a nice drawing of the ciliary body, the smooth muscle ring that surrounds the lens. In the middle would be this lens, and here's the suspensory ligament that connects to the lens and forms that boundary we talked about. But it also allows the wall of the eye to tug on the lens if we allow it. And it turns out the lens is stretchy like a piece of taffy. If you pull on it, it starts to flatten out. And if you stop pulling on it, it assumes a round shape like a marble. That's its native shape. So again, if you tug on the lens, it will stretch it and flatten out. If you contract that muscle and shrink down that ciliary zonule, the lens will no longer be tugged by the elastic wall of the eye, and it will round up like a marble. That's how it normally sits at rest. Pretty interesting, right? So let's take a look at some aspects of the optics of the eye. So here's a normal eye, and when light rays reflecting off a distant object come in through the pupil into the eye, the light rays are effectively in parallel. And what we need to do is, as they strike this boundary between this curved lens surface and the aqueous humor, they are refracted, they are bent, and if we have the lens set up just the right amount of curvature, then the light will be focused on the retina. So in our analogy, we're talking about when things come to a point, that's a sharp focused image. Looks like I've cut off some of my, I don't know if I can do anything about that, cut off some of my my text down there, and I wish I could get rid of this lower. Can I get rid of the taskbar? There we go. I can, sorry for all this fiddling around. I don't know if I can, at this late stage in the game, if I can expand my recording window. I don't know that I can. Oh, yes, I can. Nope. Okay, well, I'll have to address that another time. All right, so anyway, when the light rays from parallel rays from distant vision enter the eye, they need to be refracted, but it turns out that they need to be refracted only a minor amount. So what we're going to do is we're going to make the lens as flat as possible. We're going to do that by relaxing the ciliary body and allowing the elastic wall of the eye to tug on these suspensory ligament fibers, pulling on the lens, stretching it out and flattening it out, and getting just a little bit of refraction, which is all that's needed to focus that distant vision, that distant light onto our retina, and we can see far away very well. But however, if we switch to, oh, here's just another drawing to illustrate the exact same thing. So here's our flattened, when we activate sympathetic neurons, we have relaxation of the ciliary muscle, and we're going to stretch this lens and make it flat, and we can see long distance. If we want to look at nearby objects, here's the problem then. If we left the lens in its exact same configuration, it turns out that the rays reflecting from nearby objects are diverging. They're spreading out as they come away from this object. They enter the pupil, and now they need to be refracted, but with the lens flat, they won't be refracted enough because they're moving away. We got to really grab them and turn them inward. And so if we left the lens exactly as it was, there would be an imaginary point where these light rays would be in focus, and it would be behind the retina, and so we would see a non-sharp image. We see a fuzzy image in this case. So we have to make a change. What are we going to do? We're going to contract the ciliary muscle. We're going to take away that tension on the suspensory ligament, and what will happen? The lens will round up. That's its natural shape. And as it becomes more round, the angle with which the light rays are striking that boundary is going to be increased, and we're going to have more refraction of light. So increasing the refracting power of the lens by making it more round is how we can shift to close vision. We have to make a change in the lens to shift to close vision. And here's again just another way of illustrating that. When we look at light rays from close objects, they're divergent. We're going to contract that ciliary muscle. The little squiggly lines represent taking the tension off of the suspensory ligament. It's now slack. The lens adopts a rounder shape, a greater angle of incidence, a greater curvature of the lens, and now we have more refracting power, and we can see those rays coming from nearby objects. Okay, so that's a little abstract maybe, so if you're not sure what I'm talking about, go back and review those last couple of slides, and I think you'll see what I mean about the difference between focusing parallel rays from distant objects versus divergent rays from close objects. All right, what about people that have a little bit of trouble with vision and need some correction? Why is that? Well, a myopia is nearsightedness. That means that a myopic eye can see close-up objects well, but it can't see distant objects very well at all. It's because the eye is kind of oblong. This eye has a greater distance from the lens to the retina, so that when we have parallel rays coming into the eye, no matter how flat we make the lens, those rays are still going to converge and form a focal point too soon before we get to that distant retina. By the time the rays get back here, they're out of focus. So myopic eyes, we can make the lens, if we make the lens flat, then those divergent rays from a close-up object can be focused on the retina, because remember, they need more refraction anyway. So in this case, we can catch the close-up object's light in focus, but we can't get the distant light. So that's why it's nearsightedness. What are we going to do? We're going to put a concave lens that causes all the rays to diverge somewhat, and so now even the parallel rays we can focus later at a greater distance from the lens and have good vision, distant vision. So that's how we correct for myopia, nearsightedness. How about farsightedness? A hyperopic eye is shorter or more stubby, blunt than a normal eye. And so here the opposite problem. If we make the lens round, we can take those parallel rays that don't need as much refraction, and we can focus them successfully onto the retina and see fine. So we can see distance okay, but the divergent rays from nearby objects, no matter how round we get the lens, it's not going to be enough refraction to get a focused image before we get to that really nearby retina. It's too close. And so you can see this imaginary point where the light rays would be focused. Our vision is going to be out of focus of nearby objects. So that's called hyperopia. What do we do? We're going to put a convex lens in front of the eye to help cause all the light rays to converge a little bit more, so that now these nearby rays that needed a lot of help refracting in time are going to have that additional help, and we're going to be able to get them focused on the retina back here by causing them to converge a little bit right away through the lens. It should have done something with this ray so it would be showing the lens doing something, but hey, sorry. Anyway, that's how we correct for farsightedness. Well, it turns out that when you get to be about 42 years old, you start to become farsighted. Let's say you had normal vision, typical vision, unaided vision perhaps, and you start to become farsighted. That's called presbyopia. The problem with that is that the problem with your eye at that age is that when you want to look at close vision, what do? You contract the ciliary muscle, and it causes the lens to round up. Well, the lens starts getting stiffer and stiffer, and so when you contract the ciliary muscle, it does not round up. And so you can't accommodate and see close up very well. So you become farsighted. You can see far away okay, but you can no longer see up close. You find yourself holding your book way out in front of you, or you find yourself getting some reading glasses in order to help correct for that. So back to our picture of the retina. Now we'll have a little table of information about rods and cones, and we can review that briefly. It'll help us differentiate between the rods, those dim light functional cells that produce fuzzy vision, and the cones, color vision guys. And we can talk about transduction. We've talked about transduction quite a lot already in chapter 13, but now we're talking about transduction of light photons. So transduction of photons, what's up with that? The light rays, as we said, travel through the ganglion cells, through the bipolar neurons, bypassing them, and eventually they're going to come to the posteriormost part of these photoreceptors, and they're going to be absorbed by specialized light-sensitive structures in the stack of, you see these little disc-like appearing things in here. Those are essentially stacks of infolding of the cell membrane, so lots and lots of phospholipid bilayers in there, packed with rhodopsin. Rhodopsin is the light-sensitive component of the photoreceptors, and when light rays strike the rhodopsin, they'll be absorbed and they will make a change in the rhodopsin, and that will initiate some changes in the photoreceptors. So light rays that happen to get absorbed by a rhodopsin will allow us to see. Some of the light rays will not get absorbed. They'll pass right into this pigment epithelium and maybe be absorbed, or into the choroid back here where there's tons of pigment, and then they'll be absorbed so they don't reflect back out. All right, so a couple of cool things to note real quick here. The photoreceptors have an outer segment right here, and there's a little cilium, a tiny little appendage that connects the inner segment and the outer segment of these photoreceptors. It's probably not super important for our purposes, but it's a fact of how they're constructed. The discs that are packed with with rhodopsin, the photosensitive substance, are constantly being kind of chewed off by this epithelium. Isn't that weird? And then more being produced. So there's these stacks are always being refreshed by this epithelium gobbling up the tips of these photoreceptors, and then more and more layers of cell membrane with fresh rhodopsins are put in there. But anyway, this is where we're going to absorb the photons in this outer segment of the photoreceptors. Finally, here's this table. I need to move that table to a more ideal location, showing us the comparison between rods and cones. Rods, monochromatic, highly light sensitive, so they work in dim light, but low acuity. Acuity means sharpness of vision. Cones, they produce color vision because there's 3 different families of cones that absorb preferentially different wavelengths of light, but they need a lot more light to operate. So if you haven't ever tried this before, go into a room where there's a dimmer switch and place a brightly colored object in front of you in the bright light, and then slowly dim the light. And as the light dims, watch what happens to the richness of the color of that object. You'll see it start to dull down until it starts to look frankly gray, and it'll start to look fuzzier and fuzzier. That's shifting from the cones, which produce nice, sharp, high acuity color vision, over to the rods, which produce monochromatic, low acuity vision. So that's just the nature of things. That's why when you're walking through the dark room and you stub your toe because you can't see very well, not only because it's dim, but because you have low acuity vision in there. All right, back to signal transduction. All right, so let's take a closer look at rhodopsin. Rhodopsin consists of a protein called opsin, that's what this little dumbbell-shaped thing is, and a lipidy molecule that's this long chain of carbon. Each one of those little corners represents a carbon, and we see some other carbons appended onto that. And the carbons are numbered. There's 6 carbons in this little ring right here, and then 7, 8, 9, 10, 11. At that 11th carbon, the carbon-carbon bond is twisted 180 degrees from the other ones, and that produces a kink. And when carbon-carbon bonds are in that position where there's a kink, right here actually, that's called the cis configuration. So we have 11 cis retinal. Retinal is the name of this pigmenty or this lipidy molecule. It's derived from retinoic acid or a substance that's in carrots. It's a necessary component of making rhodopsin. Anyway, 11 cis retinal is how the light-sensitive form of rhodopsin looks. We have an opsin with this kinked retinal stuck to it. So if you just close your eyes for a long time, all of your rhodopsin will accumulate in this state. Or if you're lying in bed sleeping, right, this is how all your rhodopsin looks. Then you turn on the lights and photons begin to be absorbed by that rhodopsin. What happens? The energy from those photons causes doing, that kinked retinal will become straightened, and that cis arrangement between the at carbon 11 will be shifted to the trans position, which is the position of all the other ones. So it's straightened out, that kink. And once that happens, the retinal dissociates from the opsin, and now the opsin becomes activated. The thing is, once that happens, we'll start some signaling happening, but then this rhodopsin is now no longer available to absorb photons, so it's sort of taken out of service. And so the more this happens, the more and more of the rhodopsin gets into this non-light sensitive form, and so that's called bleaching. Bleaching means we're going to have less sensitive retinas. We're going to have less rhodopsins available to absorb photons, which is actually good because that helps us adjust to brighter light. Think of when you come from a dark room into a bright light, it's suddenly dazzling, you can't even look. It's too bright. And then eventually you start getting, quote-unquote, used to it. That means you're bleaching a lot of the rhodopsin, and then you have a manageable amount of sensitive rhodopsin left that can still absorb photons and you can still see, but it's not overwhelming. Then if you walk back into the dark room, let's go back into the dark room, coming up this side of the little diagram, coming into the dark room and no longer absorbing photons, there's an enzyme that's constantly returning the all-trans retinal to the light-sensitive 11 cis conformation. And so as we continue to accumulate our rhodopsin in that light-sensitive form, now the retina is becoming more sensitive to light. More rhodopsin is ready. So that's why at first when you walk in the dark you can't see anything, and then eventually we'll get more and more rhodopsin in the light-sensitive form, and we'll sensitize the retina a little bit more. We can see better again. So that is what happens. This is adaptation from dark to light, and then from light to dark as we go from bleached retinoic acid, or retinal, I should say, to back to the light-sensitive form in the dark. So then what? Now we need to talk more about the transduction. That's the sort of bleaching step, right? And then the restoring the sensitivity. But what happens as a result? Where's the transduction happening? We don't have any impulses yet. All right, so here we have a rhodopsin over here in this cartoon in the cell membrane of one of those photoreceptors, and a photon strikes it and converts the 11 cis retinal to the all trans form, and then the opsin becomes active. The opsin will now activate a G protein. It's a G protein coupled receptor, which we've talked about before, and then it slides around in the membrane until it strikes a phosphodiesterase enzyme. Phosphodiesterase will destroy cyclic GMP. So let me highlight something about these photoreceptors. They're so different from other electrically sensitive or stimulatable cells we've talked about. We've talked about neurons and muscle cells that are polarized at rest and can be depolarized by stimulation. When they're depolarized, then stuff happens, right? Calcium goes in the cell and we have muscle contraction. Or calcium goes in the axon terminal and neurotransmitters are released and so forth. So in this case, when the photoreceptors are at rest, there is cyclic GMP in the cytoplasm. Cation channels are open. Calcium and sodium are entering and the cells are depolarized. Let me say that one more time. These photoreceptors have open channels and are depolarized at rest. So now when light strikes the photoreceptor, we're going to destroy that cyclic GMP, and the ion channels close and the cell polarizes. It's the exact opposite of what we learned before. So the cell is depolarized at rest and then polarized when we stimulate it with light. We're getting somewhere now. All right, so let's now we can finish the story. Let's look at the entire retina. It's 3 layers of cells and see what happens when we transduce light. Here we have a photoreceptor in the dark. And that photoreceptor, we said, has open channels. Calcium and sodium are entering the cell, and it therefore has a resting membrane potential of minus 40 millivolts. Right? That's pretty depolarized. We said in those other cell types that threshold is around minus 50. We're down to minus 40. So if it's a depolarized, it's a type of neuron, essentially. Because it's depolarized, its terminals have open calcium channels, and it is exocytosing neurotransmitter all the time. Isn't that tiring to think about? All night long while you're lying in bed, these photoreceptors are dishing out neurotransmitter. The neurotransmitter binds to receptors on the bipolar neuron, and it produces IPSPs. Do you remember what that is? Inhibitory postsynaptic potentials. Chloride channels or potassium channels are opening and hyperpolarizing this bipolar neuron. And if the bipolar neuron is hyperpolarized, its calcium channels are closed. It's not releasing any neurotransmitter, and hence the ganglion cells are quiet. There's nothing happening down here. So that's what's happened. That's the dark situation. Now we're going to turn on the lights. What's going to happen? We turn on the lights, and we said that then, by the action of phosphodiesterase, we're going to get rid of the cyclic GMP, and the channels are going to close. Now what happens? When the channels are closed, the neuron polarizes, and it's no longer releasing its neurotransmitter because the calcium channels close. And that neurotransmitter, remember, was inhibitory, and it's no longer going to be released. And now we're going to learn something unique about the bipolar neurons. If they're not being actively inhibited, they spontaneously depolarize. So if we're no longer blocking these bipolar neurons, their calcium channels open up and they release neurotransmitter, excitatory neurotransmitter, onto the ganglion cells, and the ganglion cells start to produce action potentials. So that's the story. That's the whole mechanism of signal transduction in the retina put together. So again, I think it's worth going back and reviewing these two diagrams so that you can just tell that story. I want you to be able to just tell that story. What's happening in the photoreceptor, the bipolar neurons, and the ganglion cells in the dark, and what changes take place in the light that leads to these action potentials in the ganglion cells. All right, one more thing to kind of talk about with respect to vision, and that is that there's a very peculiar arrangement of photoreceptors in the retinas and where their axons go. Let me show you what I mean by that. We see here a diagram showing the entire field of view of your two eyes. And it's been color-coded to show you, like blue over here on the left, or on the right side, we're looking inferior. This is the right field of view, actually. All of these blue axons represent ganglion cells from one side of the retina, which sees this part of the field of view. Right? The right half of each retina sees kind of over to, I'm saying it backwards because we're inferior view. The left side of each retina sees the right field of view. The right side of each retina sees the left field of view. Right? Does that probably makes sense. But here's something funny. The axons from the left side of both eyes are collected together at the optic chiasma and travel back to the occipital lobe of the left hemisphere of the cerebrum. What? Yeah. So instead of all the axons from one eye going to the contralateral occipital lobe, they don't. We collect all the axons from one half of each retina, or from one half of both retinas, to one side of the one hemisphere of the cerebrum, and the others to the other hemisphere. That's peculiar. What's the implication of that, the upshot of that? Well, so I just wrote down in words what I just told you. So you don't need to gaze at this picture for a long time. The upshot of that is, if we go back to this diagram, what would happen if we lost this one of these, one eye or one optic nerve, right? What will happen if we chop out the effective, that was too graphic. What if we no longer could see with this eye, we just cover up this eye? What's going to happen? We will lose just this little bit of the field of view, because the other eye is going to help us supply everything else that we were seeing before. This eye, this remaining eye can see the entire field of view, but not this little part. Why not this part? Because the nose is sitting in the way, and so we're going to lose a little bit of the field of view. Let's see, I actually think I drew that wrong. I should have probably put this X over here. Anyway, the point is, I don't want to ruin my story. We're going to lose one little part of the field of view and some depth perception if we lose one eye. I've got to correct this drawing. However, if we damage the optic tract, once you pass the optic chiasma, if we have damaged the optic tract, where we've already congregated all of the axons from one half of both retinas together, or we lose the occipital lobe in one hemisphere, we're going to have this. We're going to have hemianopsia. We're going to have loss of one half of the field of view in both eyes. Isn't that strange? We don't normally see the two eyes function separately. It would just look like one field of view with half missing if we had hemianopsia. So that's really wild. It doesn't happen if you have a tumor or a surgery that causes damage or a trauma that affects one optic tract or one part of the one hemisphere's optical functional area, the visual cortex. Right, because we're gonna lose all of the retinas or the axons from one half of each retina. Pretty interesting. All right, let's quickly look at something to do with olfaction, and we'll end this discussion. It's been gotten a little bit away from me in terms of length. Wow. So olfaction, we'll take that quick. Here is cranial nerve 1, the olfactory bulb and olfactory nerve, and it's sitting in the cribriform plate of the ethmoid bone. And fibers from the olfactory bulb of the olfactory sensory neurons pass through the cribriform plate and down into the nasal epithelium. So these are the sensors that smell volatile or airborne chemicals that can bind to those cells. And here they are in the olfactory epithelium of the nasal cavity, on the superior surface of the nasal cavity. And odorant molecules will bind to receptors on all these little sensory cells and then cause them to send information up to the olfactory bulb, and they synapse with mitral cells in a strange kind of patterned way in these glomeruli. Each one of these glomeruli is like a tuft of terminals from a bunch of sort of randomly selected different olfactory receptor cells, and then which in turn activate one mitral cell. So if you follow these axons down from this glomerulus, you see it involves a number of different olfactory cells in a different set in this glomerulus. So there's a really interesting fact that comes from that arrangement of things in the olfactory epithelium and in the glomeruli and mitral cells. There are estimated 400 different protein receptors in these sensory neurons, in these sensory cells, that can therefore bind to 400 different chemicals, different odorants that come in the air, but yet you can detect an estimated 1 trillion different odors. So that's because it's thought that the pattern of activation of different olfactory receptors and how these groups of olfactory receptors affect different glomeruli and different mitral cells. It's a different pattern for every slightly different chemical compound. We can appreciate many, many different odors, even though there's only 400 different receptors on these different types of sensory neurons. So it's pretty wild. So another astonishing fact about special senses, when we see how do these olfactory receptors actually transduce from smell molecules into impulses, well, it's an indirect effect. This is more analogous to what we learned about with epinephrine and norepinephrine, signal transduction. An odorant molecule binds to its receptor on the sensory neuron. It's a G protein coupled receptor, so we activate a G protein, which turns on a adenylate cyclase enzyme. Adenylate cyclase causes cyclic AMP to accumulate in the cytoplasm, and that causes channels to open and depolarize that cell. So it's just like an indirect neurotransmitter effect, only in this case it's not a neurotransmitter, it's a ligand binding to its receptor on the olfactory cell. I probably should mention one last thing real quick before we go on. These olfactory sensory cells are very, very fast adapting. So if you're smelling in the presence of a strong odor and a highly concentrated compound in the air is binding to these cells, they will very quickly adapt, and you won't be overwhelmed by the smell of something for very long because it kind of dampens down as adaptation happens. The remaining receptors are not damped down so that you still have the same sensitivity to any other odor that comes into your nose, but the one that's been plaguing you or that's been stimulating your olfactory epithelium previously will no longer have the same sensitivity. All right, so let's stop there, and we'll have one more part in which we'll talk briefly about gustation, and then we'll talk again a little bit more elaborately about hearing, how do we transduce sound waves into impulses, and then we'll talk about equilibrium, balance, and your notion about your body position.